Good afternoon and welcome. I'm Betsy Pace, and I'm the board chair of Caminar. We're so glad you joined us today for our inaugural Caminar Speaker Series event, Revolutionizing Behavioral Healthcare. Some of you may have attended Caminar's in-person events before the pandemic. For those who are new to Caminar, we are a Bay Area and Northern California nonprofit, serving thousands of youth, families, and adults with mental health issues and substance use disorders. Caminar is dedicated to empowering and supporting individuals and families to move toward resilience, wellness, and independence. While we focus on caring for individuals and their families who are struggling right now, we mustn't lose sight of the hope in our future. Today's discussion about revolutionizing behavioral healthcare could not happen without the support of our generous sponsors. Special thanks to Terry Bullock, William and Janie Kind, and the 49ers organization, along with Michael and Christine Curry, Kathy and Michael Chin, Fremont Hospital, Stanford Healthcare, and PsyMed, Minette Diamond, and Vivian and Mo Verani, and our media sponsors, Punch Magazine, The Daily Journal, and San Francisco Business Times. Thank you all. I'd also like to acknowledge the work of Caminar's Board of Directors and to personally express my gratitude for their contributions throughout this year. We are so honored that 100% of the board supports Caminar with financial contributions, especially in this difficult year. We have increased our giving by 25%, and that is remarkable. Thank you. If you'd like to make a contribution too, visit our website at www.caminar.org/donate to support the compassionate and skilled clinical care that Caminar provides to treat individuals with complex issues, to reduce family suffering, and to improve our communities. Please follow us on social media to stay connected. And with that, I'm very excited to introduce Caminar's CEO, Mark Cloutier, who will be the moderator of today's discussion.
Thank you for the welcome message, Betsy. Good afternoon, everyone. My name is Mark Cloutier, and I'm the CEO of Caminar. Thank you for joining us on our inaugural speaker series, Revolutionizing Behavioral Healthcare, using new technology, brain science, and equity-oriented treatment to make us all better. Immediately preceding the COVID-19 pandemic in California, like the rest of the United States, was seeing a reduction in life expectancy, which began in 2014 and went for multiple years in a row, leading to the greatest sustained decline in life expectancy since 1920. Americans died younger and younger due to drugs, alcohol, and suicide. This continued through the first half of 2020 when COVID was first appearing. Then COVID struck. Deaths due to the virus, lockdowns, loss of income or housing, school closures, and pulsing of opening and closing activities have created a whole new wave of mental health and substance use issues. Simply put, demand for behavioral health services cannot keep pace with the available supply of services. Community behavioral health providers like Caminar are primary deliverers of behavioral health at a population level. Serving low-income members of our communities, organizations like Caminar provide hope and recovery for millions of Californians. As you know, behavioral health care is absolutely critical in reducing homelessness, reducing our jail and prison populations, and bolstering people's ability to successfully engage in primary medical care. The opportunity to reduce emergency room use, job losses due to addiction or severe mental health symptoms, failed marriages, broken families, and successful completion of education does lead to enduring economic and health benefits. And more importantly, it also reduces a lot of human suffering. However, the challenges placed on community behavioral health providers like Caminar, combined with the new opportunities of technologies, new ways to pay for care, as well as addressing the social determinants of health and racism, all could substantially improve the mental well-being of our communities and our nation. Caminar, as a community mental health provider, sits in an ecosphere driven by these dynamics. Let's begin our conversation to unpack how we can capture these opportunities that are truly revolutionary in the way that they could fundamentally remake behavioral health. Allow me, please, to introduce our panel. With me in the room is Dr. Sandra Hernandez, who's a physician and the president and CEO of the California Healthcare Foundation. Before joining the California Healthcare Foundation, Sandra was the CEO of the San Francisco Foundation for 16 years, where I had the great pleasure to work with her. Previous to that, she served as Director of Public Health for the City and County of San Francisco and chaired San Francisco's Universal Healthcare Council, which led to the first city in the United States having universal healthcare coverage. In 2018, Sandra was appointed by Governor Brown to the Covered California Board, and in 2019, she was appointed by Governor Newsom to head the Healthy California for All Commission. We also have Dr. Tom Enzol, who is a psychiatrist and neuroscientist, and was the former director of the National Institutes of Mental Health. He's also a co-founder and chairman of Humanest. He previously served as Governor Newsom's principal advisor on the Mental Health Board, the director and was a professor of psychiatry at Emory University. More recently, he led the mental health team at Verily, formerly Google Life Sciences, and co-founded MindStrong. Tom is a member of the National Academy of Medicine and has received numerous national and international awards, including honorary degrees in the US and Europe. And Dr. Ben Miller, who is joining us, who's the Chief Strategy Officer for Wellbeing Trust, a national foundation committed to advancing the mental, social, and spiritual health of the nation. Wellbeing's goal is to end the inaction around mental health and to advance a national movement to promote mental health and well-being. Dr. Miller spent 8 years as an associate professor in the Department of Family Medicine at the University of Colorado School of Medicine, and he is currently an adjunct professor in the Department of Psychiatry and Behavioral Sciences in the Stanford School of Medicine. So beginning with Sandra, would you please share a brief statement about what you see as the urgency of reforming behavioral health care now?
Sure. Thank you, Mark. It's a pleasure to be with you and with Ben and Tom this morning. The concept of revolutionizing behavioral healthcare really is what's at stake. California Healthcare Foundation does a poll of low-income Californians to really understand what their priorities are with regard to healthcare and healthcare access. And pre-pandemic, the survey indicated that access to behavioral health and mental health services in particular were far and away the priority for low-income folks all across the state of California. And of course, now we're well over a year into a pandemic, and what we've seen, of course, for all the reasons you mentioned earlier, Mark, the economic impact, the isolation, lack of people being able to access regular sources of care, have all really exacerbated what is a real priority for the people of California, and a real necessity in particular for low-income folks throughout the state. CHCF spends a bulk of its time really focusing on the Medi-Cal program that serves a third of all Californians. And so the data that came from this poll really does argue for us to look at this ecosystem that you described, Mark, and really think about how we revolutionize it to really make it meet the needs of all Californians, and in particular, our low-income communities.
Thank you. Tom, would you like to state the urgency from your perspective?
Oh, gosh, as Sandra was saying, and by the way, let me just add my thanks to being included, and it's really a pleasure to do this with you, Mark, and with Sandra and Ben. I'm sure the four of us could probably take up the whole afternoon with just fun conversation about these topics. But the urgency is felt on so many fronts. What strikes me the most at this moment in time, which was not so apparent a year ago, are certainly the issues around equity, right? That this has been, I used to say that the year 2020 would be the year we'd have perfect vision. And as a country, we'd be able to see so many things. And unfortunately, I'm afraid that turned out to be true. I think we got a sense of just how big some of the social justice challenges were. And I think we'll get into this more as the conversation goes on. But where I see this for mental health, particularly, is so different from COVID than where we are for the infectious disease challenge. It's so interesting when you map out the demographics. If you're thinking about the virus, you think about largely people over 65, now people over 40, but largely it's people in the second half of life who are at the greatest risk of morbidity and mortality from COVID-19. The psychological consequences, which have created the urgency of this moment for mental health, are all the first half of life. And it's really striking. It's mostly people under the age of 24, school age and university aged, that are showing the greatest amount of distress during the pandemic for lots of the reasons that you've already articulated. They are really vulnerable to this. And my sense is that young people of color are even more at risk. We already saw that they had the highest change in suicide rates before. That continues to play out in the last 12 months as well. So that's where I would start to focus in terms of urgency right now.
Ben, where would you start with describing the sense of urgency?
Well, thanks, Mark. And I want to echo my thanks to you for holding this conversation today, because it does feel like it's an important one and matters now. I felt that urgency has existed in our field for quite a while. And as you alluded to in the beginning remarks that you offered, since 1999, when we've been tracking this precipitous rise in deaths to drug, alcohol, and suicide, or what the economists have called deaths of despair, deaths that are related to mental health, addiction, but also driven in large part by social factors such as loneliness, stigma, and economic factors such as job loss. It just seems like that we've been needing to do something in that space for some time. In case in point, I don't know if anybody saw, but in today's New York Times, more people died from drug overdoses in San Francisco than coronavirus in this past year. Drug deaths in the city, which were about 2 a day, and they point to the root cause of despair in the article, and they highlight this about the devastating loss of people's jobs and not having homes and being on the streets. So we're still in the middle of that, and it's put mental health on everyone's radar. Wellbeing Trust is a collaboration with Kaiser Family Foundation, and we've seen in their data this ongoing consistent trend that mental health is on everyone's mind. Last summer, it was about 53% of us described how mental health, depression, anxiety was something that we were struggling with. It's about 47% now, a little bit lower, but still very high when you consider that. So it feels like mental health has been pushed to the side in a lot of our conversations, especially around the COVID response. Sure, we've seen stories about successes of getting meals and arms and all of that. It's important. We need to do that. But we also need to address underlying all of that, our nation's mental health and addiction crisis, because we haven't been able to do that just yet. So things aren't working, but we continue on. We have to. We can't afford to stop. People will continue to suffer if conversations like the one we're going to have today don't lead to action.
Thank you, Ben. So a question to Sandra. It goes in part to your polling and an issue that Tom raised, which is we know that the mental health impacts have been primarily on younger people and primarily on younger females. What do we know about this, and what should it suggest about how we approach fixing this?
Well, just building on Tom's remarks, I think the pandemic has had an extraordinarily intense impact on women. Women who were in the workplace, were suddenly not in the workplace, displaced either because their jobs evaporated during the pandemic or because they needed to stay home and teach their kids how to learn on Zoom and to do childcare. And so I think the pandemic in general has had a disproportionate impact on women, on low-income women, on mothers, and of course, on young women in general. And so, it seems to me that as we think about programs and programs that work, it's really important for us to look at the policy environment that influences so much of what our delivery system does and does not provide for. And so things like universal child care and paid family leave, there are so many systemic policies that have an impact on those social determinants that disproportionately impact low-income families, and in particular, families that are led by women. And so I think, post-pandemic, we had a pre-existing need and really gap in service availability for people who needed mental health care. Another one of our surveys showed that less than 30% of people who wanted and needed mental health care could figure out how to get it or access it. I noted there was a quote from one of your clients, Mark, that they felt lucky to be able to come to Caminar and find the services they need. And all too often, that is what it takes, luck. It is really hard to navigate the systems of care that we have, the way that we finance them, the way that we organize them. And I think we have to take a holistic look at these social determinants and address them in a comprehensive way with a particular focus on the impact it has on low-income families and on working families who are struggling with economic needs, with job needs. And if you have a child that has a pre-existing mental health issue, those challenges are just compounded enormously.
Tom or Ben, do you want to add to that?
Just one comment, and I think Sandra said this really well, but for so many families, it's a lottery as to what you're going to get, if you can get anything when it comes to services. And so I think along with the conversations that we have around increasing access, enhancing affordability, we also need to talk about quality and the type of care that people get, where they get it, who delivers it, to be creative in that discussions. Because I feel like if we rely on people to continually come to us for care, and we don't look at some of the community level issues that really require us to get out and go to them, I think we're going to miss a pretty unique opportunity.
Yeah, I was going to make exactly the same comment, but I'll add on to what Ben said. I think it's more than access, right? It's going to be access with quality plus engagement. And engagement is a little different than access. Engagement says it's finding people where they are, helping them to get services in the way they want them, and then most importantly, helping them to stay in services in the way they want them. The company that I've recently co-founded, Humanest Care, was founded to solve just that problem. The only problem we were going after was engagement. We know that more than 50% of people who should be in care are not. They're not coming to Caminar, they're not coming to the county, they're not coming anywhere until they're in crisis. And often that means they're going to be in the criminal justice system, not in the healthcare system. And that's egregious. That's unacceptable. But it's on us to figure out how to solve that. It's not like we can just build a nicer clinic and they'll show up. It's figuring out how to get to people and engage them where they are, as Ben was saying. What makes this so different from oncology, cardiovascular, diabetes is that in mental health, as anybody at Caminar knows, the more severely disabled somebody is, the more severe their illness, the less likely they are to engage. And that becomes a huge challenge, right? Figuring out how do you get to people who may not want to be in care and yet who certainly are going to need it. And when they don't get it, end up getting care in a way that's involuntary, which nobody wants. But that's the world we're in right now. That's part of what we have to solve for beyond just access.
So I do want to go back to access, Tom, and ask you a question. Sandra shared this statistic that 30% of people could not find care. And as she said, most people who find care find themselves to be lucky that they found it. What is our problem with access and coverage? Why is this such a conundrum for so many people?
Yeah, Mark, I'll make the conundrum harder. because usually when you say there's an access problem, it's because we don't have enough providers. So how many providers are there in the mental health workforce, according to the federal government? Well, that number from SAMHSA is 600,000. So just to give that some context, how many primary care docs are there in the nation? About 200,000. How many dentists? Less than 200,000. So we have a massive workforce. We have the biggest workforce in healthcare, in what we broadly call the mental health care workforce. Of course, only about 5% of those are psychiatrists. And to get to Ben's point, when you ask about quality and what kind of training do those 600,000 people have, what can they actually provide? It's really striking, right? So what you find out is only a handful of people out of the 600,000, and I mean hundreds of people, not thousands, have the skill set to treat somebody with anorexia nervosa with an evidence-based treatment, to treat somebody with borderline personality with an evidence-based treatment. We have good treatments for many of these disorders, psychological treatments. Very, very few people are trained to provide them, which is, again, egregious, hard to believe. The other piece of it is, for many of those who do have the skills and for those who have the most training, they're not taking insurance. They're not taking private insurance or public insurance because they don't have to, and because the insurance by itself isn't going to be able to compensate them the way they can charge out of pocket. 52% of psychiatrists in America don't take Medicare or Medicaid, and about 42% don't take any commercial insurance. That is not true. You know, the joke is it's really hard to find a psychiatrist that takes insurance. It's really hard to find a pediatrician who doesn't. And that's just the reality that we have to deal with. So that means, again, going back to your original questions about transforming the system and thinking about systemic change, figuring out how to create a reimbursement system that is inclusive and engaging of the providers, which right now we really lack. They are outside of both public and private insurance for the most part.
Great.
Yeah, Mark, maybe if I could just build on that a little bit. Number of the healthcare foundations in the state of California came together just before Newsom took office as governor, with an eye towards really trying to create a roadmap for the workforce that we needed in California. One that was, well-trained and evidence-based. And one of the major areas of focus was in the area of behavioral health. And we could talk about psychiatrists. Addictionologists are even fewer and harder to identify. And I think one of the policy areas that is clear is really thinking about the stigma, inherent stigma in the training programs when people are deciding what kind of specialty they're going to go into to begin with. If you look at psychiatric training programs in California, they have not grown the number of slots in 40, 50 years. So I think, this is one of these areas in workforce where we should do everything we can to leverage the existing workforce to be able to use evidence-based treatments. But we also have to really think about what we're subsidizing and how we're incentivizing and how our training programs are able to grow both psychiatrists and addictionologists, but also help primary care providers do a lot better with using the evidence that exists now and really leveraging that workforce as well. Tom mentioned the number of primary care providers we have. That's also a shortage we're going to look at. But I think we're starting to look now at models that allow us to leverage our primary care workforce with other behavioral health components that are culturally appropriate and that allow us to get access to what is right now a very limited supply of those providers. So again, I think it's a systemic look at how we incentivize it, how our academic programs think about what they're producing in the workforce, and really have it meet the needs of this really significantly underserved population, both mild to moderate and people with severe mental illness. And there are models for this to leverage it, but I think we need to step back and really look at what is our output, and is it meeting the needs of the population that is subsidized? These programs are all subsidized by federal dollars, and we really should stop and look at that. And the Workforce Commission report has a number of recommendations in that regard.
It's
So
a
a
great
question.
report, Sandra. If I can just jump in on that, because there
Sure.
are two things in that I just want to add. Actually, I use that workforce report all the time. It's like probably the best document, particularly for California. It's got great data in it. But there are two recommendations that I think we really ought to take to heart, because in addition to increasing the number of professionals on the MD and addiction side, uh, the report stresses that we've been really deficient on nurse practitioners. It's a really important piece of the workforce that we've neglected and is way, way under-resourced, and particularly in mental health. I think in the entire nation, there's something like 13,000 nurse practitioners. That number is about 10% of what we actually need, would be an important place to focus. And then the report also stresses the need for people with lived experience, and even those who are without lived experience, but who have lower levels of training and can come in as mental health workers. I'm not sure how important that is in the world of pathology, anesthesiology, cardiovascular surgery, but in mental health, to have a workforce that looks exactly like and comes from the communities that you're trying to serve is absolutely essential. And we have failed to do that. And we're not going to do that by just training more psychiatrists and psychologists, but using people from those communities and giving them the basic skills to be able to serve in the community. I think it's a piece of that workforce recommendation, and it's a really great place for the California policymakers to focus.
So let me pick up on that for a second and say, one of the challenges with the workforce is that we don't have a good match between what the workforce is and the culture and language needs of the people who are seeking services. Let's drill a little deeper on that, and I'll start with Sandra. What are some remedies that we could put in place to address this?
Well, I think Tom names one that's super important, and that is an existing workforce that I would argue is under-tapped, under-realized, and really under-recognized. And those are community health workers. We have community health worker infrastructure throughout the state of California. They tend to be funded in small pockets on grant funding to do particular types of programs. But what makes them such a useful part of our workforce in this area potentially is that they are by and for the community. They speak the language, they're trusted. They can have the conversations that sometimes stigma makes hard to have. And it's a workforce that it has enormous capabilities in culture, language, and trust, which are absolutely integral in the area of behavioral health, whether it's addiction or whether it's mental illness. Absolutely critical that you have those components in place. What we haven't historically had is a credentialing program that would allow systems of care and hospitals and health plans to be able to take up that workforce and be able to deploy it alongside our professional workforce, and frankly, create career ladders for folks who are in those programs to be able to go on and go get nursing degrees or nurse practitioner degrees or the like. And so we've seen that workforce be able to do amazing things in prevention and education and a lot of other diseases. It's a workforce that we believe is an untapped asset that could benefit significantly in these areas that all of our studies and reports will identify as a huge need, Mark.
Thank you. So stigma keeps coming up. There's stigma in all parts of this. Ben, you've done research on stigma. What do we know about stigma and how it drives people's inability or even awareness that they might need care?
Well, thanks for the question. Let's start by defining stigma. The term itself, stigma, comes from the Latin and Greek words that basically mean a mark on the skin. Back then, it was made by a hot iron. I mean, it gets a little gruesome. I've been studying a lot of this with my 13-year-old, believe it or not. She hasn't talked about stigma, but she is studying like ancient history. And so forgive me for geeking out just a bit here. But this mark in ancient Greece, it identified criminals, slaves, outcasts, people who weren't trusted, thought to be dangerous, and were avoided at all costs. And so if we apply that to today, there's actually a model that's really helpful. And it looks at how we can think about stigma as difference plus deviance. So I'm going to just kind of go 2 steps further on this, but it's really helpful to get this right. Because in the difference phase, an in-group marks an out-group. So it could be, you're depressed, I'm not. Depression is not what most people have. I don't have it, and so I'm in and you're out. In the deviance phase, we actually go a step further and we treat that person differently. So you have depression, and now I'm going to treat you differently. I'm going to shun you, I'm going to mock you, I'm going to aggressively be mean to you. There's deviance. But because stigma has in-groups and out-groups, it's inherently social. And we spend a lot of our time these days talking about the social side of stigma, how we can discuss it more openly with our friends, with our colleagues, how we can put up new billboards to normalize it. And I think that's important. But I think the one thing that we have to also understand about stigma is that it's also inherently structural, that it comes down to places like, how do we, if you're a child in a school and you raise your hand on the day that someone asks a question and you're admitting that you've had thoughts of suicide, and the first response is a police officer showing up at your school. That is a structural stigma. It reinforces the difference plus the deviance. And I think that that's an area that we could do a much better job in, because stigma, as we discuss it openly, it matters to get right. Because if we only did the social side without doing the structural side simultaneously, we're never going to kind of fix this fundamental flaw that we've got in our system around how we treat people differently who express mental health or addiction needs.
Yeah, Ben, I just want to build on that. You reminded me of how much work there is to do on really breaking down the stigma, in particular of mental illness. My daughter had a friend who in middle school was cutting, and there was a lot of awareness of it. And what was interesting to me is parents, it's a private school here in San Francisco, and parents who are colleagues would call me and say, your daughter is spending a lot of time with child X, and I don't know if you know or not, but she's been cutting. And I said, no, we know, and we've had the conversation, and we've encouraged our daughter to stay in relationship. And I think we have a lot of work to do in our schools to help young people and their parents really understand that staying in relationship as opposed to ostracizing, because somehow if you're hanging out with a child who's doing this, that's not good for you. We just have a lot of work to do on really breaking down these long-standing barriers around stigma. And by the way, stigma occurs, as we said, in all of these institutions. And I think our young people really are our future and suffer greatly, as we said at the top of the program, from this. And so teaching mental health interventions in peers and peer-based support is another area, I think, in particular in adolescent mental health, where there's a lot of literature that we have not yet put fully into play and reimbursed and seen as really a priority from a wellness point of view, and helping people learn how to help people who are struggling.
Just
I like
one
those
comment.
comments a lot. If I can just jump in, because I'd love to be a little bit controversial here.
Please.
Yeah, I have a book coming out called Recovery, and there's a chapter on sort of pleading with the community to ban the word stigma. I think stigma is actually a term that perpetuates the thing that we try to get rid of. It's a victim word. It's a passive word, and I've been trying to replace it with the word discrimination, because what we're really concerned about is much more really it's more like a civil rights problem than a tattoo stigmata problem, the way you were introducing it, Ben. And I like your formulation of difference, because I think there's a bit of that, and then that kind of judgmental piece that comes in thereafter. But I think if we as leaders want to begin to change the conversation, we have to change it to something that's more empowering, more active, and that builds on this really as a social justice, civil rights issue, not an issue of victimhood and passivity. So it's a little bit around, speaking of geeking out, there's a little bit around just the terminology and the language, but I think words matter. And I have been over 20 years now involved in so many anti-stigma campaigns. I've yet to see one of them have any impact whatsoever. But I think if you begin to mount a civil rights campaign that says that we can no longer discriminate against people who have a disorder like this, that I think will get some traction.
Tom, I love that. I mean, I can't wait to read the book. I think you're right. And I do think it's a discriminatory issue that we face. And we experience this in things like health insurance, right? The discrimination of what gets covered versus what doesn't get covered for mental health. And I think it's an important topic, but I want to pick up on something you said, and I don't think this is controversial at all. Maybe it will be, but I'm a big fan that we as leaders have a responsibility to use language that reflects the type of culture that we're trying to create. And this is a hard thing to do because I do believe that language changes culture. But even the language that we've been given or gifted or inherited or the legacy of someone else is flawed in how we actually use it. I mean, the word mental health as just one example. We know that health is multifaceted. We know that mental health is a fundamental part of our health. But when we talk about health is health is health, if we don't say the word mental health, people believe that it's something that got left out, when it should be naturally part of our dialogue. So I think there's always going to be those lexical, ontological language issues that really do kind of put us in a space that to change the culture, we're going to have to figure out that language piece.
Let me move to another question.
Totally agree.
Let me move to another question and we can come back to this. So we're obviously on the edge of Silicon Valley here. There's been a lot of development of new techniques and technologies to apply to mental health. In your blueprint, Ben, Wellbeing Trust, Healing the Nation, Patrick Kennedy, the former member of Congress, talks about the need to get technology out. One of the problems that you cite in your blueprint is that less than half the counties in the United States have a practicing psychiatrist in them. So we have this bad distribution geographically that's impairing a lot of people's ability to get care. What is the hope of telehealth, and what do you think we need to do to optimize it?
Okay, there's a lot to unpack here. I actually can't wait for my colleagues to weigh in on this one because I think we're going to have an interesting dialogue. First of all, telehealth is not a new concept. I mean, you can find the origins of this modern telemedicine traced back to the early 1900s, mainly in Europe. In the US, we can see it around the 1950s with cardiograms being shared back and forth. But the idea of telephone is important, but it's not new. So what is new is that COVID has allowed for the loosening of restrictions that allow for clinicians to use these different applications. So specifically, to get a little bit wonky, and you can follow me here, HIPAA-covered healthcare providers can, if they're using it in good faith, offer telehealth services through certain apps like FaceTime, Facebook Messenger, Google Hangouts. That's a radical change, where we saw in the data that we analyzed from utilization that we went from like 1% of mental health visits to 75% of mental health visits over the course of like a few months. So it skyrocketed. And so we have used it. So prior to 2020, only 1% of mental health was delivered via telehealth. And as I mentioned, that analysis that we did with Milliman showed that it skyrocketed to 75% in 2020. And just one more point on this, because I think it's really critical, that telehealth should be seen as a way to augment some of the clinical and relationships that we have within our healthcare settings. But how do we assure that telehealth or any technology does not reinforce a silo? Does not, we've moved so wonderfully. I give, Sandra and a lot of folks in the state a lot of credit for this. We've moved wonderfully towards more team-based models of care. And I worry that if we put too much weight on a one-to-one intervention that occurs through telehealth device, that we actually take us away from that team-based environment. A second thing I do think a lot about for telehealth is how do we make sure it doesn't exacerbate disparities? And I know that a lot of folks are paying attention to this issue, but from lack of broadband devices to devices themselves, we've got to make sure that all communities can benefit equally from technology. And then finally, for the telehealth piece, how do we allow for choice? How do we allow it to be built in to a part of a person's care pathway where they might decide to start with telehealth or might not? How do we avoid pushing technology on someone just because it's available and easier, and allow for the patient to actually have the choice in what they use there? So I'll close with just one quick comment here. I mean, it goes back to workforce, because I think a lot of things go back to workforce. But we've got to think creatively about how to meet people where they are. And in Healing the Nation, we talk about this. We talk about the points. I love Tom's word about engagement. How do you find the places that you can engage a person? In some cases, it's their home. In other cases, it might be the prison or the jail where we have put them and they don't need to be. In other cases, it might be a school or a pediatric office. Technology can help us enhance our overall capacity. But if we lean too heavily on technology, especially just the telehealth provision, there's a lot of other technology out there, then I'm afraid that it actually could take us a little bit away from some of our intended goals to meet communities' needs.
Yeah, Mark, if I could just jump in on
Sure.
that. Ben raised a whole bunch of really interesting issues around this. I mean, the piece I would name, and I think all the concerns that Ben raises are quite legitimate. There is no one size fits all. And I think we had to learn that. That's sort of a core tenet of this. But one of the things that happened with 2020, and one of the reasons we went from less than 5% to 70%, was there was a declaration of a state of emergency, which I would argue was in place in the area of behavioral health well before the pandemic. But that emergency actually allowed for Medi-Cal providers to be able to be paid to be able to do telemedicine and telepsychiatry in ways that literally from a Friday to a Monday were incredibly accelerated. And for people living in rural areas all across the country and the state, I have a nephew in New Mexico, lives in a town of 2,100 people. I mean, to be able to access psychiatry services through technology is an accelerant for a limited workforce, which we already talked about. But if you don't actually allow for payment, and to Ben's point, this whole notion of team-based care is so important. And our federally qualified health centers, which serve a disproportionate number of our low-income communities all throughout the state of California and the country, they could not actually see a patient for diabetes or hypertension or coronary artery disease or renal insufficiency, and if they had a psychiatric condition, be paid for that person to see somebody on the same day. I mean, literally, those were our policies. It took a pandemic, an emergency, to waive that and to acknowledge that the notion that we'll see you today for this illness and I'll see you tomorrow for the next because I can't get paid to see you on the same day for the same problem, it really is a descriptor for how poorly we think about what it is we're trying to achieve in outcomes and how we build these systems to actually work for the patients themselves. So we see telemedicine as a huge opportunity to reach folks that you couldn't otherwise reach, and payment allows for that to happen. California is about to undertake arguably in 3 decades, the largest rethink of our Medi-Cal program. And what we're trying to do in that program is look at the whole person and then ask ourselves, how do we build the services around them? And to your point, Ben, it's so important that we not continue to have data in one system for mental health issues and concerns and physical health in completely different data systems. Right. And right now we have that too. And we have all these boutique data systems out there. And so all of these things need to be integrated in a patient-centered kind of way. And telehealth and telepsychiatry is a tool that works for some people in some circumstances, and payment shouldn't really get in the way of that.
Tom, I've
if I
heard
could
you
just
talk.
add one thing,
Yeah, go for it.
just because I think these are really important points, and I agree with Sandra that the payment reform, allowing people to get reimbursed for a remote visit the same way they would have gotten reimbursed in 2019 for a face-to-face visit, huge. In California, it hasn't quite solved the problem of access.
Mhm.
That's geographic. It works fine within the state, but my clinicians, my licensed clinicians in California who are psychotherapists, are not permitted by state licensure regulations to provide care to people in Nevada or Oregon or anywhere else that's actually outside of California. So even though Medi-Cal says they can be reimbursed, the state licensing board has this restraining order around their being able to provide the services. You could say, well, people in Nevada can go to someone in Nevada. The problem with this, with teletherapy, first of all, is that that's ridiculous when you're talking about remote care. But beyond that, a huge part of the access problem is the geographic disparities. If you look at psychiatrists, Idaho has 5.6 per 100,000. Massachusetts has 28 per 100,000. You would think that teletherapy would solve that problem, and it will once we get the licensing boards to provide a little more flexibility. This is a case where the federal government has actually been way out ahead of the states. CMS has said, yeah, we'll pay you, but we still have to get the permission. And the greatest irony of that is that our mental health workers who are not licensed but provide therapy as well can see anybody anywhere. It's our licensed providers who are restricted.
Tom, I want to follow up with you because you've described telehealth as we're in telehealth 1.0. We've talked about some of the limits of that. What could telehealth 2.0 look like, and how could it address this issue of access and affordability?
Well, I think 1.0 has done a pretty good job on access. So that's, it provides the convenience factor that Sandra and Ben already talked about. And that's great. And it's not for everybody. The New York Times ran this wonderful piece back in the summer about how not everybody has the privacy to do this. And the title of the piece was, in 2020, the toilet is the new couch, which I think is actually a very clever construct. But the thing that really kind of focuses for me on the opportunity is beyond access. It's beyond saying, hey, we can do what we were doing in a brick and mortar office. We can do that on Zoom, or we can do that over Skype or on the phone. I think what we ought to be asking is this the opportunity to get at the things that Ben started with, saying we need to go after not just access, but quality? And I mean, for me, there's sort of three problems to solve. I mentioned engagement. There's also a problem around quality. And quality requires really good metrics and requires better integration of data, and it requires more transparency. And wow, technology can solve those problems with the tools we have right now. The third problem is accountability. So really being able to measure outcomes. To be fair, we did a lousy job on that in the brick and mortar system that we had prior to the pandemic. This is the opportunity to start to bake in accountability, to be able to bake in all the kinds of measurement that we've been missing in this field. If you don't measure, your confidence grows faster than your competence. That is a fundamental law of nature. This is the only field I know of in all of medicine where there is almost no measurement of outcomes. The only measurement we have generally is whether someone's continuing to show up, and if they are they continuing to pay? And will the insurance company cover that? That's what we define as outcomes. No other part of medicine would do that. So we need to start thinking about, can telehealth 2.0 come with all of the tools that we can use to be able to actually monitor quality of care, integration of care, coordination of care, and outcomes, so that we know what's working and what isn't, and both the patient and the provider get that feedback, and then the competence can grow. It can become a learning health system, which so far we have entirely missed in behavioral health.
Tom, I just want to make a little plug for my own organization. We are measuring outcomes, and we've just started this, and we believe it's a fundamental obligation that we have to our peers and our communities to tell them what we're doing with their resources to get the community better. So I think you're going to find a lot of support and willingness from the delivery system to make progress on this.
Technology can help you. It can empower you to do that in a way that doesn't have a huge burden, which is really the most important piece to get adoption. It can't require a lot of time or effort from either patient or provider, and that's where some of these new tools can be so useful.
While I have you, Tom, we're talking a bit about the future here. Where are there opportunities in neurology or brain science that you see coming down the pike that could change how mental health care is delivered or the outcomes that people might experience?
Not so much. Honestly, there's great science and there's huge progress in science, but that's on a different track. I think What we need to focus on are the simple things. There's not going to be any magic bullet.
Right.
As much as everybody's hoping that the next drug will be the answer, there isn't going to be one of those. These are complicated problems, and what we have to focus on is just the kinds of things that Sandra and Ben have been talking about. Is how do we coordinate better? How do we ensure in the simple things? How do we just make sure we have teams that are working well together? At the end of the day, this is all about care. And I think what happens in Silicon Valley, where I live and work and where my companies are, is that we get so wrapped up in the bells and whistles and we think that there's going to be some really cool thing that we can invent that will change everything. And actually, that may be the case for banking, and it may be the case for transportation and for some kinds of communication. There's lots of places where that may be true. I don't think mental health is one of them. I think this is ultimately going to require both high tech and high touch. And the real use of technology is in facilitating the high touch, making it easier to provide care, coordinate care, and and have the kinds of models that we know work, like collaborative care, that we're not doing. And that's what we've got to use the technology for. So I'm not looking so much to some brand new imaging finding or some biomarker that shows up from the, RNA profiling. All that stuff is really cool. And maybe by 2040, it'll give us something that we can use. But in the short run, we just got to stay focused on how do we provide better care.
Well, let's go to that because Sandra raised an issue. She brought up the issue of CalAIM, which is the fundamental reform of the state's Medi-Cal program, the biggest reform in 30 years. At its heart, as Sandra mentioned, is integration of care across physical health, dental health, mental health. What can we expect to see happen from this reform, and what would it look like? How might users of behavioral health services see that difference in coming years?
Well, let me start with this, Mark. First, let me tie it to really what Tom was talking about a moment ago. There are models that work now. Ben and I were able to sit with a group of folks, I don't know, a couple of years ago, really looking at some of the models that work and trying to understand what the nature of they were and kind of what their central design elements were. Again, to begin to envision what a CalAIM program might be able ultimately deliver. And I know you remember this, Ben. We had a presentation from a clinic in Alaska with Native Alaskans that was really performing poorly on all measures of outcome. High suicide rates, high alcoholism rates, very poor health, physical health outcomes. And really that clinic was overtaken by clients themselves and Native Alaskans themselves. This is part of the Indian Health Services. It wasn't necessarily an incredibly well financially resourced system, but the central elements of it were that clients themselves designed what was important. And every single one of, and so pediatricians and primary care docs were consultants. They were not centrally running this clinic. And over the course of a decade, they completely transformed the outcomes that were most important to this patient population in this village that was served by this clinic. And so I think it's really important for us to recognize that if we actually take people with lived experience and problem solve our delivery system around what they need and want, all of our financing systems, CalAIM, whatever, would do much better by them. Right now, our systems are largely driven by arcane rules and payment mechanisms. And so what we have now as an opportunity in CalAIM is to look at the whole person and to really think about how we integrate information around their needs. I mean, a number of us are clinicians in the room, and all of us were trained, start with subjective. How are you? And what is important to you to solve today? And really fundamentally, that's what we're talking about in the models and principles around integrating care for CalAIM and really doing a team-based care where the patient themselves are really at the center of identifying those priorities that matter most in their life. And that really, at its most simple terms, there's a lot of different stakeholders involved. And by the way, frankly, a lot of our stakeholders promote the same systems of care that, as Tom so wisely said, just have not worked. We've measured processes and visits and really have lost focus on what it is we're trying to do. And so CalAIM, trying to integrate care, try to use team-based care, and try to pay people to do what's right to achieve the kind of outcomes you want, at its most basic, is what CalAIM is aiming to do. And it's an enormous both promise, and I think we should recognize it's doable if we're significantly willing to drop down the systems and barriers that have not delivered the kinds of outcomes that people really want and deserve.
Ben or Tom, any comments on CalAIM and what we can expect?
I'll just make one quick comment because I'm sure Tom's got some too, and I'll be very brief with this one. That there is the promise of a new future with CalAIM. And I think that the things that we've seen in the past in other states, including California, that have not worked is when we only take on a piece of the transformation. We only make it about delivery, and we don't bring in the financing, or we don't bring in the administrative or the policy changes. And I think undergirding the opportunity here is a recognition that we have to pull multiple levers at once. And that, for any state, any organization, is hard in the best of times. It's even more difficult when you're a state the size of California and you have complexity coming out your ears. So I think that there's an opportunity here, and this is going to be a dangerous word to say, but I'm going to say it anyway. I think there's an opportunity here within CalAIM to simplify. Because my goodness, the end user, the person who is out there trying to figure out a way to get from point A to point B, the complexity that they have to face every single day is almost at the point of unethical. It's just horrible that the end user has to work that hard. So I can't wait to see what happens. I hope it's a guide for the rest of the nation.
Yeah, I'll just add, in 2019, I took a year to help Governor Newsom by traveling around the state and talking to people in the either managed care sector, the specialty county-based mental health sector, and then in the criminal justice system, homeless shelters. I did the whole 9 yards across California. And one of the things I heard lots. One of the things I heard that really struck me was from the people in the county-based systems. In almost every county, I heard the same thing. And they said, what's broken here is the way we get paid. We have to account for every minute of our time. So we end up spending almost 30% of our time accounting for our time. That's what the administrative burden had become. And they said, when I was saying, well, wouldn't it be great to have more nurse practitioners and more psychiatrists? They said, oh, yeah, that'd be great. But you want 30% more people in the workforce? Just fix that. Just get rid of that administrative burden, change the reimbursement requirement, and you'll have 30% more people, or 30% more of your workforce actually doing what they're supposed to do. And CalAIM does that. So CalAIM begins that process. It's not everything we want, but it's a huge, huge step forward. And as Sandra said, it really gets us towards integration in a way that California so badly needs it. California is such a complex, as Ben said. It's mind-boggling how difficult it is for consumers, but also for anyone to try to navigate this state's 58 mental health care systems, because that's how many there are. Every county does it differently. But I think CalAIM does at least start by saying, hey, there's no wrong door. We're going to go after whole person care as the model. We're going to integrate to the extent that we can. And we're going to try to fix some of the low-hanging fruit that's just ready to be done. And I got to say, this is a new day. I think this is super exciting that California is undertaking this. The governor's taking it seriously. You see how much money he's going to put into it in this first year. If nothing else, if it just attracted that much from general fund from the state, that alone would be a good thing. So I think this is a moment to celebrate for what California is doing. How it rolls out, we'll have to see. But really, for anybody like at Caminar or anywhere else in the state who's in this space, this is a big deal. This is probably the most important advance in the last 4 decades for California.
Tom, I'm sure my staff were clapping when they heard the reduction in the time of recording the services. It's the bane of every behavioral health provider's work. I want to shift for a minute to behavioral health provided in non-traditional settings. For many people, correctional settings has become the de facto mental health system. I want to ask Ben, what kind of care is available in our correctional systems? And how could we do a better job of transitioning people to the community and supporting them?
Well, I think as most people know, we've seen this uptick in criminalizing mental illness and addiction for decades. And so I think we have to start by examining assumptions that care is about coming to us. And we've really got to look at creative ways to take it to them, like jails and prisons. So criminal justice reform, this is a major public health issue. It's a human rights issue. It's even an economic issue. Inappropriate incarceration, it wastes millions of dollars annually in addition to all these ongoing justice expenses. We can do so much better. This is a quote that's often given, but when you talk about the LA County Jail as the largest mental health provider in the country, you know that there's a problem. So I think we need to do 3 things at once, and I'll be very brief with these so my colleagues can weigh in. One, I think we need to work on diversion. We need to divert. So we need to keep people who are in crisis away from prisons and jails. We need to have mobile crisis teams, crisis residential facilities, psych ERs, and so much more. With 988 on the horizon coming in July of next year, it's an opportunity to really think creatively about a full continuum of care. That requires us to have a good diversion program. I look a lot at the Judge Steve Lifeman in South Florida that many people are familiar with. This guy for over 20 years has been doing some of the most innovative diversion and has got this criminal mental health court that allows for folks who are arrested, for a mental health or addiction crisis to actually not go to prison, but to be connected to care. So that's number one, we got to divert. Number two, we've got to divert and then we've got to treat. Too many people who are incarcerated have a mental health illness, and depending on where you might look at the data, it's 37% in like a locally run jail, 45 plus in a federally run prison. 1 in 4 folks are experiencing some type of psychological distress in jails, and 3/4 of people in federal prisons, which I have worked in, by the way, did not receive any mental health care. So as we talk about integrating care, which I think we have an opportunity to do, let's don't forget about integrating care into places like jails and prisons where care is so desperately needed. And then finally, number 3, we got to figure out a way to help folks when they are released or decarcerated. Offering flexible coverage options for Medicaid to cover people as they re-enter the community is an easy example that I know many states are pursuing, but we also need to connect these folks to services. If you were on MAT in prison and you were discharged and you no longer have access to that medication, the risk that you might OD when you get out is very high. So at the same time we do all these things, we've got to recognize that we have to integrate the criminal justice system within the healthcare system too, and connect the dots. Sandra said this really nicely, that we don't want to inadvertently create more silos of care. We've got to figure out a way that these silos are connected. Some of that's through data, some of that's through financing. A lot of that is just through good leadership and good vision.
Ben, I really like the way you broke that down. It reminded me of something that happened to me recently. As I was finishing my book, I have a whole chapter on how unacceptable it is that so much mental health care is only given in the criminal justice system. And I sent that chapter to a young psychiatrist who I just wanted to have him kind of fact check it and tell me what he thought. And he called me later and he said, last week I was in San Quentin with a patient. This is a young guy who does forensics and works in the jails and prisons. And he said, I was talking to a 24-year-old guy who'd been in San Quentin for a couple of years and is due to be released next week. And while we were talking, he just broke down. And I said, well, are you worried about being released? He actually used the word discharged, which tells you exactly what the mentality was there. And what came out was that this young guy was terrified that once he got out, he wouldn't be able to get care again.
Yeah.
So as I mean, that's sort of the greatest indictment I can think of, of our mental health care system, that people have to be incarcerated to get care. Um, so as awful as it is that we are giving care in the criminal justice system instead of the healthcare system, for many people, that's as good as it gets.
Yeah, your comments, Ben, make me think about what we've all been watching as we're talking about police reform. So many calls that police officers get called to, they're actually not the right workforce to deploy to what the need is. And so, to your point, as localities all across the country are really thinking about how do you reduce police violence and police deaths, thinking about 9/11 calls and when they come in, and what do you send out in terms of crisis teams and the like, and what kind of training do they have to be able to address those crises when they occur, would be so much part of this solution as we're looking at criminal justice reform more broadly. And on the reentry piece, this is something that's actually being piloted in California, where people who get released can actually get connected to a behavioral health provider, such that you don't get interruptions in medical assisted treatments, because the risk of just needing some ongoing med that you're not able to get puts you at risk for significant deaths associated with overdoses and the like. So completely agree with everything that you said, and really thinking about deploying the right workforce in these acute settings and communities, to me, is such an important part of what we need to be able to do in mobilizing a better response.
Now I'd like to turn the conversation to prevention. There's this question of how much mental illness and addiction we could prevent. And the question comes down to really how much productivity, lost educational opportunities, foregone economic activity, broken marriages, and disability days due to mental illness exist. We know from an article that was published in The Lancet in 2020, the estimate of the cost of untreated mental health was at $1 trillion to the US economy. What if you were to be given $1 billion, what would you spend it on in terms of prevention? What do we know from an evidence-based early intervention perspective does the most to reduce later development of mental health or substance abuse disorders?
Maybe I'll start. I'm sure everybody's got thoughts about this. Given that the costs are $1 trillion, spending $1 billion does feel a little bit like you're under-resourcing a tough problem. And Mark, you talked about an evidence base, and it's, frankly, prevention research is hard, right? You need large groups of people who you assume are at a particular kind of risk, and then you're trying to measure something where it doesn't happen. So these are the kinds of trials that are not for the faint of heart, and they take a long time to do well. That said, the recent data was just summarized in a paper in Nature about a year ago on prevention for depression. Was actually very impressive, that in studies done for women at risk, mostly these are perinatal women who were deemed to be at higher risk for depression, they were able to drop the prevalence of depression in that population by 50%. And that's looking at a whole range of different studies. So this was a meta-analysis, sometimes more than 50%, sometimes a little bit less. But if that were a drug, that'd be a pretty impressive effect size to be able to do that, because this wasn't just like reducing symptoms. This was preventing the illness altogether. Pretty awesome that we're able to do that. So it's a message that there is an evidence base out there for what we can do. The example that I like the best is actually moving much, much earlier and looking at that first 1,000 days. And I'm particularly, because I used to run NIMH, and we funded the Nurse Family Partnership Program through David Olds through 3 decades. I sometimes think that was the best investment we ever made, when you look at where that is now and what that is able to do, what we've learned. And what's so stunning about that nurse-family partnership, which helps moms prior to their delivery, stays with them through the first, I think, 18 months with multiple visits and it's a whole range of skills that are brought into that transaction. It's really, really impressive. You see the effect not just on the mom and on that baby, but now because we've had this long enough, we can see the cascade of effects when that baby grows up and becomes a mom. And it's extraordinary. Threefold differences in Medicaid usage for the offspring when they grow up. Fourfold difference in criminal justice involvement. I mean, just these are enormous effects. When the RAND Corporation looked at this project to say, what is the return on investment here? They came up in 2005 with the comment that for every dollar spent on nurse-family partnership, we get back $5.86 just in that first generation, likely far beyond that in the second generation. So yeah, this is evidence-based. We know this works. Why we're not doing this across the country in millions of moms at risk, I don't know. I think we don't have the political will, but we know it needs to be done. It's really time to take projects like that, preventive projects, and put them in play.
I know there's been a lot of investment also in social emotional learning in schools as trying to forestall or prevent downstream mental illness. What do we know about social emotional learning? Ben, I'll start with you.
Yeah, well, quite a bit. I mean, this is where, as Tom was saying about early opportunities for intervention, if our kids don't know how to regulate emotion and understand how to communicate how they feel and what they're thinking, then when they become adults, when they become big people, and that regulation isn't there, it's all kinds of problems. And so when I think about the opportunities upstream and I think about the power of prevention, sure, there's a big need to get into schools and to make sure that every child is exposed to some type of social emotional curriculum. That is like a basic necessity that I feel like if we don't offer, then we've missed a big opportunity. But I think it goes beyond that too, because remember, mom and dad, they may not have had that training. Mom and dad might be suffering through poverty, not having stable housing. So when I think about the previous question, and I'm going to connect two dots here, I think about, well, okay, $1 billion, first of all, I agree with Tom, is budget dust. We probably shouldn't even play with that small amount because we need more for mental health because the underinvestment here has not allowed us to be creative with prevention. I immediately think of issues around poverty. I really think about going deep into communities and investing in the places that people live so that they can have a foundation for their overall success. I mean, we don't typically think of that as prevention for mental health, but my goodness, if you're constantly walking out on the street, on the sidewalk, worried about your safety, or you can't lock your front door, which we heard about sometimes talking to folks that were unhoused in San Francisco, that does not bode well for your overall mental health. And so I think that we have to do something fundamental there. But besides that, yes, invest in schools, invest in the kids, go upstream there. But if you're going to think bigger in the checkbooks, a little bit more broad than $1 billion, I'd address issues around poverty and socioeconomic issues.
Yeah, let me
Hey,
just
Ben, what do you think about reducing the Biden administration's commitment to reduce child poverty by 50%? You think that's a mental health policy?
Absolutely.
I absolutely do. Absolutely.
Yeah, I was just going to say, to your point, Tom, is where I think you were going. We don't typically think about these other policies, but universal income, much more lengthy paid parental leave, universal preschool. Really, if we're going to support families early on, because, look at trauma-informed care where we're just assessing traumas that occurred during those years. And so I think we need to think about these policies that impact those families when those children are very young, because as Tom notes, you get generational impact from doing that. And so I think we have to look at those kinds of programs that really do support people who are extremely stressed and all the trauma that people are exposed to in those families, in those environments, and identify those policies that will really strengthen the ability of those parents early in their years to have time to not be worried about an income, to be able to get young people early into into child care programs. I mean, these are the kinds of policies that we've seen in Europe and elsewhere. They're not billion-dollar policies, but they're very much central to the prevention of the kinds of things that we're talking about.
Yeah, this is such an important point, Sandra. UNESCO has looked at policies across the developed world, 32 countries, and we are really special in America. There's no question. We come out at number 32 year after year after year. We are well behind. There are 197 countries that provide paid family leave. There's only one country I know of now that Western Samoa has done it, and Albania has done it. We're the last country that is not providing any sort of family leave policy. So this is, we're exceptional. We really are exceptional here. So when you hear the administration talk about we're going to do something around child poverty, you've got to put that in the context that we are where other countries were 4 decades ago. We're just beginning to do the things that almost any other developed country realized was part of what you do as the moral determinants of health. And we have missed that.
I want to turn us to, we're running out of time, and turn us to, we've raised a lot of issues about revolutionizing behavioral health care. There's lots of opportunities for change of payment reform, how people use care, going deeper into the social determinants of health. What would you say to our listening audience about what is actually going to change within the next 2 years? And Sandra, I'll start with you.
Well, look, what I would say as a closing thought is that anybody in any part of the system that believes, yeah, the system's broken, but what I do is fine, that's the very first thing we have to change. Because really, there is no part of the system that we have today that fundamentally is meeting the needs that we've all talked about since the beginning of the program. And so my own view is that we will make a dent in childhood poverty. That would be a huge benefit. And I do think we'll implement CalAIM. It will cause a lot of disruption, and a lot of providers will claim, what we were doing before wasn't great, but it's what we know. And what I'd like us to think about is what's possible, what the evidence can lead us to do, and how we really do mobilize a movement that does not accept the status quo as we know it today. And what I am sure of is that post-pandemic, the movement for better behavioral health, better mental health, simplifying a system of care, and creating a system of accountability for better outcomes is something that this movement will clearly have developed over the next 2 years.
Ben or Tom, adding to that?
I'll go quickly. I mean, I think the genie's out of the bottle. The country has experienced what mental health is the last 12 to 13 months. This is no longer something that we can just point at someone else and say that's their issue. This is all of our issues. Every family, every child, we've experienced what I would classify as mental health in the last year. And I think that's important. So when I think about the next 2 years, and I want to go back to what Sandra just said, I think the revolution is afoot. I think that there are folks out there, when we go back to whatever we go back to, it will not be the status quo. It will not be the thing that it was. It will be something new. And I think that the folks who are experiencing this crisis firsthand are going to demand for something better. I think that the providers who are out there doing their best are going to demand for something better. And I think when we look in the eyes of the kids, of the moms who are really struggling, of everyone out there, we're going to see hope, because what they are going to do is they're going to rally together and push for something better. I don't know how to be more optimistic about this, because I never had a moment as propitious as the one that we're in now that allows us to get mental health at the forefront of everyone's agenda. As we just discussed, this is not just about delivery. This is not just about the mental health system. This is about where people live. It's about where they work. It's about how they worship. It's about our country. And if we're going to be serious about changing mental health, it is the community who we're serving. We should listen to them, and we should follow their lead, because I trust where they're going.
Tom, I don't mean to cut you off, but we've run out of time. I want to thank our speakers, Dr. Tom Enzol, Dr. Sandra Hernandez, Dr. Ben Miller, for joining us. And Thank you for being a part of our inaugural speaker series. This is the first of many where Caminar will bring together speakers and a table to explore issues in behavioral health. Thank you for joining us. I hope you have a safe weekend. Take care.